Welcome back to Blood and Guts podcast, Surgical Expert Breakdown. And I'm very excited today to have a very well-respected surgeon from my area, Virginia, which is where I am, to really talk today, not really about medical legal things, but about surgical education. Because as you know, one of the hats I wear, and I've been doing it for a while as the doctor we're going to meet today, is really teaching, training, and educating medical students and residents. And I think personally, I think that makes me a better doctor. So I'd like to introduce Dr. Paula Ferrada. She is currently the surgery chairman, Inova Fairfax Hospital. I was with her at VCU, Virginia Commonwealth University. Now she is seeing bigger and better things. So thank you for joining, Dr. Ferrada.
Dr. Cohen, for me, it's a pleasure and a privilege to share this time with you.
Great. So give us a little bit about how you got to where you are.
That's a very interesting question. That I have to ask myself sometimes. The path is that I'm from Colombia. I was born in Cali, Colombia, where there was a lot of trauma. My dad was the chief of surgery for the hospital, the university hospital. In Latin America, there's different rules. So my dad used to take me to work when I was a kid. So the first time that I scrubbed in a case, I was 12 years old. And I grew up in the hospital. I'm not saying this is the right or the wrong thing, but you asked me about me. So
Right.
So I have been around patient care, and my mom is an OB-GYN nurse. So I have been around patient care since I was 12. And so when I decided to go to medical school, it kind of felt like I was home. And coming to the United States, I came to the University of Miami. I did research there. Then I went to Beth Israel Deaconess, where I did my residency. And then I went to University of Pittsburgh when I did one of my fellowships. And I went to shock trauma and did a second fellowship. And I spent 11 years at VCU in different roles. Started from assistant, then to associate, then professor. I was part of the MCV board. I had the opportunity to train multiple residents and medical students. I always have loved teaching, whether when I was in residency with the Harvard medical students or at VCU, is being part of what I do. I feel that when you look at leadership roles, which are important and needed, I think a good mentor and a good teacher, those skills overlap. I'm not saying that leadership, you have to train yourself and you have to understand it, and you have to train yourself the way that you learn any skill, like taking a nappy or taking a gallbladder out. But I think if you're a good mentor and if you're a good teacher, then leading a team and that pleasure and that joy that you feel for developing people, it translates, whether you're doing it with residents, with fellows, with students, or with faculty.
And that's a great point, but I have you beat by a year. So my dad is a retired general surgeon. He's still alive. And my first operation, I was 11.
Oh, wow.
So I have you beat. And I got sick to my stomach. I was nauseous and I was trying hard not to faint, but I was 11. I mean, it's not my fault.
No,
So,
no, no, no. It's like it's that its own is that's why sometimes when I think about when I think about, people ask me, how did you choose surgery and how did you choose trauma? And I think that I like it chose me rather than the other way around.
right.
Yeah.
Right. And that's a good way. So let me ask, the first question is, how do you balance? Because now you're chairman of a department, you're busy as can be. How do you balance running a high volume trauma center with your responsibilities of surgical education and training?
I am gonna say this is how I do it. I don't Doesn't mean that this is how everybody should do it. I'm gonna confess and be vulnerable right here. I'm not the most balanced person. In fact, I don't believe much in balance, because balance implies that you have to take something from one side to give to the other. When I'm at home, I try to be, and I succeed at being, sometimes, the majority of the time,
Mhm.
being present, being a mom, being a wife, being a stepmom, right? Being a doggy mom, all the things that you have to do at home, and try to disconnect as much as possible. And when I'm at work, I'm 100% at work. And sometimes something happens in your life, somebody's sick and you cannot do it, or you have a emergency at work and you cannot be that much present. But I try to separate it as much as possible, because when I am doing whatever job that I'm doing, whether it's the job of being a mom, or the job of being a trauma surgeon, or the job of being an administrator, I give it 100%. There's no give and take from other places, and there's no balance. I am passionate, and I think, and I believe that we all make time for what we think is important, right? So everybody complains about, oh, how are we going to do time management? This, I don't think it's time management. I think it's energy management.
Yeah.
And I think if you're really passionate about what you do, you get the stamina and you get the energy, and you find ways around it. No, so somebody asked me, so what do you do for yourself? Not much for myself, but I think I enjoy what I do so much that I'm a happy person. I'm happy where I'm at. I'm happy with my career. And I consider that, I think that's success, happiness.
Right. That's a really good point, because and I had the same conversation with people. For my daughter, her happy place is going shopping, right? My
Yeah.
happy place is doing what I'm doing. If I'm working, I'm reviewing a case, I'm operating, teaching the resident, that's my happy place. I'm fine with that, right? So, and I feel the same way. But let me ask you about surgical training. So, the way we do surgery now is different than we did in the 80s and 90s, right? Whole different ball game. um, what innovations or changes have you made in your organization in a surgical training program to better prepare for the complexities and the changes in trauma care?
I think that's a great question. In terms of protocol, I think in the last 10 years, not only I brought it to Inova, and now we're pioneers nationally on this, but I think I have been working on that since before. Changing the paradigm from trauma, from the ABCs to CABs, and delay intubation as long as possible, so you can resuscitate the patient, so you cannot just follow a protocol just because you're following a protocol and then
Right,
with a dead patient. ATLS says that any GCS below 8 needs to be intubated, but if you're bleeding to death, you're not gonna have a great GCS, right? You're required to be alive to be able to think. So, and speak and all those things. So that could be one. But I think in general, I think the most important, but that's a great project, and I think it's gonna save a lot of lives. That being said, I think if I'm gonna say the most powerful contribution that I had to Inova, to my residents, our students, our fellows, and our faculty, is a culture of safety, a culture of not finding who to blame when something bad happens, but a culture where we can hold each other accountable without shaming and blaming. Uh, because
very, very different from the 1980s. I was shamed and blamed every day. That's
every
right.
everybody was shamed and blamed every day. The culture of surgery was one that it used to terrify people, right?
Right. Yep.
But we know now that culture of shaming and blaming, that leads to is inversely proportional to accountability, because if you're afraid of admitting your mistakes, you're going to hide them, you're not going to look into
Right.
them, you're not going to even like talk about them, and more importantly, causes burnout, and it hurts retention and recruitment for people. So
Right.
we work, yeah, assuming everybody shows up to the hospital to do the best that they can, and
Right.
not only talking about trainees and surgeons, but everybody, nurses, respiratory therapists, emergency medicine, internal
Right.
medicine. Nobody shows up to thinking today is the day that I'm going to do something to hurt somebody, right?
Right. Right.
So I think if I can, and it's not, the credit is not mine, it's my team, we did it together. But I think if I'm gonna name one contribution in the last 4 years that I have been in Innova, is to having a more fairness, less blame, and less shaming culture, and be able to be vulnerable with each other without fear
Right.
of retribution.
Right. No, that's great. That's important, because there's many things I did. I won't say it because this is a recorded call, to hide the chest X-ray of the pneumothorax, so I didn't have to present it. Right. There was no electronic medical record. If I didn't bring the hard copy film, nobody saw it. And some days I couldn't find the film. I don't know what happened to it. I won't say it.
Right.
Let me ask you another question. Do you have any example where you've actually adapted or changed your teaching method based on any feedback from the residents?
Yes, absolutely. I think I used to because I grew up the way that I grew up, and where I went to residency, there was a Socratic method. That's what it was. So that's what I used to do. And because we know, like, our students are paying at least what, $200 per day or per week. So I was like, how you get to get your bang for your buck. If I tell you the things, the chances that you're going to remember is less than 10%. If
Right.
you tell me the things, and it's like the equivalent of you teaching because you went somewhere, you got the resource, and then you presented, the chances of remembering are 70%. It's not still 100, but it's something that we can do better. But then I realized that it deeply intimidates some people. So
Right.
for the extroverts and for the people that know what they're talking about, they have studied and they know, and they want to be challenged, those people come to the forefront and they raise their hands, and they want to participate. And for the people that are not so sure and they're a little shy and they're behind, they're a little bit behind, or their learning path is different, it's tremendously intimidating to do that. So I think I learned with time to approach teaching and learning with more curiosity and less judgment, and
Right.
try to listen a lot, and also catch the micro expressions, because sometimes people might not, like, sometimes you get the feedback and that's golden. If somebody tells you, hey, can you do this better, oh my god, like, treasure that, right?
Yeah. Right.
But not a lot of people are in the higher that you go up, less people are going to be brave enough to give you feedback. So you have to
Right.
relying on observing, feeling. You're going to feel it, and be very attentive of micro expressions and body language. So
Right.
I definitely have changed that approach. Yeah.
Yeah. No, that's good. That's important because you're right. Not everyone's going to tell you. Right.
Right.
That's for sure. Let me ask you a question about, because you have some old surgeons like me and you have some young surgeons. With the increasing complexity of trauma cases and trauma care and the changes, how do you make sure that both the new surgeons or the older surgeons stay up to date in terms of uh, the latest surgical protocols?
So one great thing that we do in most surgical departments is morbidity and mortality. And these, I have to give the credit to the residents, because the residents get
Mm.
into a complication, they're emotionally attached to it, which is wonderful. You have to have emotions. Like in surgery,
Right.
we're taught, oh no, there's no crying in surgery. And there's absolutely crying in surgery. There's nothing more devastating than pouring your heart and soul to make a patient better and have that patient have a complication.
Yeah.
And having something preventable. Your heart is going to break in million pieces, and I will also say that if it doesn't break in million pieces, then maybe your call is not in healthcare, right? We
Right.
need to be invested emotionally in the outcomes of our patients. It's not the emotion that is bad, it's what we do with it and how we react to it. So if
Right.
you have these residents are emotionally invested and they get into a complication, they're going to go there and they're going to look at the latest literature and what has been produced and bring it to the forefront. And that's when us as faculty members need to turn our listening ears and actually be able to consider other points of views, because science, and especially surgery, changes. Look at trauma. Look at, we were giving salt water to people 10 years ago. We now know that we give whole blood and FSP, but it's only through questioning those paradigms and those
Right.
doctrines, right?
Yep.
The most dangerous phrase in medicine is, we always have done it this way.
That drives me crazy.
Yeah.
Drives me crazy. That's right.
So I think, so to your point of education, I think education and quality improvement programs, when they're done well, they elevate everybody's intellect.
Right. No, and I think that's why when I started this, I said it makes me a better doctor because
Yeah.
there's, the way I was taught 30 years ago is very different now for sure. and things continue to change. And I'm anxious about what's going to happen the next 30 years in surgery. How do you see virtual reality or artificial intelligence in the field that you're in currently in terms of doing it, using it, or teaching it?
I think I think we all need to get with the program that AI is the future. I think
Yep.
that there's no denial. If you deny it, then you're going to be a dinosaur, and we all know what happens.
It's almost like laparoscopy in 1990. Don't do laparoscopy. That I had a staff guy tell me that. That's ridiculous. That's malpractice. Okay, here we are.
Yeah, exactly. So I think it's a skill, and we all need to learn about it. I think AI has interesting things to offer in terms of like operating room efficiency, operating room scheduling. I think that is a huge part of AI. And I think all these simulation things with virtual reality, it's super cool what you can see when you can and what you can do. I don't believe that that will be done for the immediate trauma because you don't have time. Those are time sensitive decisions, but definitely for the training to get you there for sure. And there's things that we're exploring currently in Inova. One of my partners has a grant, so we can amplify our learning through those experiences.
I interviewed a physician who's working with a AI virtual reality model for radiology, where he puts on and it's like it's all 3D and he can rotate it. It's amazing. I mean, it is a game changer.
Yeah, I
For
agree.
planning elective surgery, liver resections, Whipple. You can see everything. It's amazing.
Yeah,
It's amazing.
And for us surgeons, it's fitting because we are visual learners, right?
Right.
The
Right.
old paradigm of you see one, you do one, you teach one. It's not like
Right.
that anymore. But you definitely can see way more now when we have these tools at our disposal.
Yeah. So I want to end on a question that I ask all doctors because I know my answer, but I want to hear your answer. Looking back in your career, knowing what you know now about medicine, two questions. Number one, would you go back through medical school again? And if yes, would you pick the same field or a different field?
Those are great questions. And for me, it's like super easy because I feel it in my heart. I will definitely do the same. And I had the privilege of starting medical school when I graduated from high school. So I started medical school in 1994 at 16 years old.
Oh, wow.
I think so. Which makes me very ignorant in anything that is not medicine. So I am aware of that. So I'm trying to train myself in other skills. But I definitely will do it again. It's very gratifying. I'm not gonna say for those that are listening that are in medical school, yes, there are days that you think like, why am I doing this, right? And it's delayed gratification. You're gonna see friends are already earning big paychecks and you're not. But you're not in it. You're in this for different reasons. I think there's definitely not that we don't want to get paid fairly. Of course we do, but there's a component of a vocation and feeling pride and of the privilege of being taking care of patients when they need us the most, when they're in their most vulnerable. And trauma, so I consider all the fellowships. I was like, oh, I'm going to do vascular surgery, but I'm going to take trauma for fun. I'm going to do transplant surgery, but I'm going to take trauma for fun. I the date. And then I absolutely, that's why I'm telling you, I know that I am deeply unbalanced, but I own it and I enjoy it. I never felt more alive than when you go to the trauma bay and you have somebody that is deeply ill and something that you do with your team, of course, because it's not it's a contact sport and it's a team sport. Mm-hmm. That's something that you do to that patient that gives them a second chance at survival. And there's no better high than feeling that way. It's something great that you do for your patients, and it's something great that you do for you. Helping people is, and there's tons of data about it. There's reasons. Increased dopamine, increased serotonin, increased oxytocin is the way that we prevent a workforce from being burned out is allowing autonomy and allowing us to take care of the patients the way that we need to take care of them without some of the administrative overhead.
No, that's a great point. And I feel the same way when I'm doing hemorrhoid surgery. See, so we are glad that there are trauma surgeons out there like you But I really appreciate it. Thanks so much for being with us, and good luck in the future. We're going to hear good things from you, I'm sure.
Thank you so much. This has been fun.